Hi everyone, my name is Silvia Canelón, and thanks for joining me today to talk about the impact of sickle cell status on adverse delivery outcomes using electronic health record data. I'm a postdoctoral research scientist at the University of Pennsylvania, where I work in the Department of Biostatistics, Epidemiology, and Informatics. I don't have any relevant relationships with commercial interests to disclose, but I would like to acknowledge Dr. Mary Regina Boland, the principal investigator of the lab that I work in, and our collaborator on the study, Dr. Samantha Butts, as well as several other Boland lab members. Learning objectives for this talk include understanding how electronic health record, or EHR data, were leveraged to study the impact of sickle cell disease on adverse delivery outcomes, including stillbirth, and hematological outcomes, like blood transfusion and hemorrhage during delivery. This study was motivated by the fact that pregnant people are often underrepresented in clinical research, as are ethnic and racial minorities. Those that are pregnant and have sickle cell have been shown to be at an increased risk of adverse outcomes. And the granularity of our dataset enables the study of pregnancy-specific contributions to the risk of a clinical complication at the time of delivery. We also estimate a higher incidence of sickle cell trait at Penn Medicine compared to national estimates, meaning the size of our dataset makes studying pregnancy outcomes among people with sickle cell trait and sickle cell disease feasible. For our analysis, we used our Madi algorithm. Madi stands for Method to Acquire Delivery Date Information from the EHR, to identify over 63,000 distinct deliveries from records of over 1 million female patients with visits to Penn Medicine between 2010 and 2017. We identified delivery and hematological outcomes of interest occurring within the patient's delivery episode, or episodes if they had more than one. And we constructed generalized logistic regression models to assess the risk of a variety of predictors on delivery and hematological outcomes. So what is sickle cell disease? It's a complex inherited genetic disorder and the most common hemoglobinopathy in the US, affecting around 100,000 people. It primarily affects individuals of African ancestry, and it's associated with high lifetime morbidity and premature mortality. Inheriting one hemoglobin S gene results in sickle cell trait, whereas inheriting two abnormal genes results in sickle cell disease. The disease is characterized by abnormal hemoglobin and sickle red blood cells. The sickle cells die early, so they're the ones on the slide on the right-hand side, which causes a constant shortage of red blood cells, or anemia. These sickle-shaped cells are also hard and sticky and block capillaries, causing myriad downstream effects, including debilitating pain in the form of pain crises, and other serious problems such as infection, acute chest syndrome, and stroke. To help prevent these complications and manage their condition, people with sickle cell often require blood transfusions. And people with sickle cell trait still produce sickle cells, but perhaps not at a level that would result in detectable symptoms. So our study, as I mentioned, involved obtaining electronic health records from Penn Medicine, identifying female patients that were treated at inpatient or outpatient clinics, using ICD-9 and ICD-10 diagnosis and procedure codes to identify patients with deliveries. And then we used our Madi algorithm to identify specific deliveries for each patient. And then followed up again with ICD-9 and 10 codes to identify patients that have been diagnosed with either sickle cell trait or sickle cell disease. In our study, these were two mutually exclusive groups that combined represented a group that had some kind of sickle cell mutation, and these were 2,068 patients and almost 2,700 deliveries. So identifying the distinct delivery episodes with the Madi algorithm involved looking at one patient's timeline. So this slide shows a diagram of what that timeline could look like, where there's one delivery on the left-hand side of the diagram and a separate second delivery happening on the right-hand side of the diagram. So what the algorithm does is it uses delivery billing codes and identifies when they're occurring within a patient's timeline, and then separates one delivery from another, thereby inferring when each delivery took place. So in this diagram, there are two distinct delivery episodes and a variety of delivery codes that define the beginning and the end of each delivery episode. When we wanted to identify outcomes within these delivery episodes, we also utilized ICD codes and then mapped a pregnancy-related outcome to each of the delivery episodes in terms of whether they were occurring within that same delivery window. The patient population at Penn Medicine is shown on this slide, where the top table shows the breakdown by sickle cell status. So altogether, there are 50,560 patients with deliveries, and there were over 63,000 deliveries from the overall group. And then of these, most patients, so almost 96%, did not have any kind of sickle cell mutation, and about 2,000 had a sickle cell mutation. Most of these had sickle cell trait, and a smaller portion had sickle cell disease. And then the table on the bottom half of the slide shows the racial and ethnic breakdown of patients that did have some kind of sickle cell mutation. And what's highlighted on this table is the fact that almost 93% of the patients with some kind of sickle cell mutation self-identified as Black or African American. For our logistic regression model, as I mentioned earlier, we studied different delivery outcomes, including C-section, preterm birth, and stillbirth, as well as hematological outcomes, including a blood transfusion, hemorrhage, and pain crisis, which we all found to be relevant to the context of sickle cell disease. And then in terms of the predictors that went into these models, we of course considered sickle cell status, so whether a patient had sickle cell trait or not, and whether a patient had sickle cell disease or not, the number of pain crises that a patient might have experienced before delivery, as well as the number of blood transfusions that a patient might have received before delivery. We also included in the model and accounted for a delivery episode. So was this the patient's first pregnancy, second pregnancy, and so on. Whether or not the patient had a prior C-section, whether the patient had a multiple birth diagnosis or a multiple gestation, the patient age, their marital status in terms of whether or not they were married, the race and ethnicity of the patient, the blood type and the blood Rh factor, as well as the year of the delivery. For this talk, I'll focus on stillbirth, blood transfusion, and hemorrhage as the outcomes. This slide shows the rates of stillbirth over time, where on the left-hand side, we start with January of 2010, or the period from January to March, and then on the right-hand side, we end at 2017. So we see that there is ups and downs over time, nothing in particular that stands out a lot. In terms of the model results, I'll point out here on this forest plot that sickle cell trait and sickle cell disease were both associated with an increased risk of stillbirth. So a patient with sickle cell trait, the increased risk was almost 9 times greater than patients without sickle cell trait, and with patients with sickle cell disease was almost 27 times greater. I'll also point out that the last line in this forest plot indicates that the interaction effect of a patient self-identifying as Black or African American and having sickle cell had a considerably lower risk of stillbirth than those patients that self-identified as Black or African American but did not have a sickle cell mutation, indicating that perhaps patients with a sickle cell mutation may be receiving care on a more regular basis and perhaps be able to avoid some of these severe adverse delivery outcomes. This slide shows blood transfusion rates over time, again from 2010 to 2017. And something interesting to note here, and I'll talk about later on in the talk, is that in 2015, there's a very sharp decline that continues into 2016 and 2017. And so that's not because there somehow were almost no blood transfusions at Penn Medicine in 2016 and 2017, but actually more of a result of a change in coding practices. The results of this model showed that sickle cell disease significantly increased the risk of a blood transfusion during delivery, and there were several other predictors that were also found to be associated. This slide shows rates of hemorrhage over time from 2010 to 2017. Again, you can see that in 2011 and 2012, the rates were considerably higher and then dropped between 2013 and 2017 to more or less consistent levels. The results of our model for hemorrhage interestingly showed us that neither sickle cell trait nor sickle cell disease were found to be significant predictors of hemorrhage during delivery, which is important considering that hemorrhage is a severe maternal morbidity. Some of the limitations of this study include that we didn't include data on hemoglobin variants, which would help confirm sickle cell status, identify patients with homozygous sickle cell disease, which is the most severe form, and identify heterozygous patients that are asymptomatic. In addition, as I'm sure this audience knows, billing codes like ICD-9 or ICD-10 are imperfect at capturing clinical conditions. A great example would be blood transfusion capture and how after the transition to ICD-10, it was limited by a change in coding practices. So in April of 2016, the Alliance for Innovation on Maternal Health issued a data alert for blood transfusions after hearing that hospitals were electing not to code blood transfusions due to the complexity of codes accompanying ICD-10. The alert is linked on this slide and includes coding guidance to support staff. In conclusion, patients with sickle cell disease were not found to be at an increased risk of hemorrhage, which is a severe maternal morbidity. Pregnancies of patients with sickle cell were at an increased risk of blood transfusions and stillbirth. And the results overall underscore the need for systemic support for comprehensive, coordinated care for sickle cell patients, particularly during pregnancy and delivery. You'll be able to view the full results of this study and read more about it in our upcoming preprint. Please stay tuned on my website for more information, and the link is provided on this slide. Thanks again for being here to listen to my talk. This slide contains links and information about where you can find me, my personal website, on Twitter, or on GitHub. Thanks again.